the vital signs. We'll talk about the vital signs. First we'll talk about the prerequisites, then we'll talk about pulse, blood pressure, respiratory and temperature. Okay, so under prerequisites, first we need the instruments. We have a stethoscope, we need a blood pressure cuff, and we need a thermometer. And we need a watch, right? We need a watch, and we need a watch that measures time in seconds. The watch will measure time in seconds. And we need a measuring tape as well. It's best to have a measuring tape. Do you have it? So these are the things that we need to measure the vital signs. Okay. So after we've completed all the prerequisites, including the consent from the patient, then we will proceed to palpate the pulse. Okay. So how I will palpate the pulse is, first I will palpate the radial pulse. So first I need to locate the radial artery. Okay. So radial artery is located on the front of the wrist or on the ventral aspect of the wrist, just lateral to the tendon of flexor carpi radialis. Okay, so we will palpate just lateral to the tendon of flexor carpi radialis, and we can locate the tendon if we ask the patient to flex the wrist. Can you please try to flex the wrist? Okay, so if he tries to flex the wrist, then I will see two prominent tendons. Okay, the medial one is the tendon of palmaris longus. If you come a little bit closer, I will show it to you. Zoom. Okay. Then the lateral one is the tendon of flexor carpi radialis. So I'm going to palpate just lateral to this tendon. Okay. So the specific technique is that I am going to hold his hand as if I am going to perform a handshake. Okay. So I am holding his hand, right hand with my right hand, and then I will slightly flex his right hand, and I will place it in the semi-pronated position. Okay, so this is supinated, this is pronated, this is semi-pronated. Okay, so then I am going to palpate the pulse with the pulp of my three fingers, middle finger, index finger and ring finger. With these three fingers I am going to palpate just lateral to that tendon. Okay, so then I will feel the radial pulse. Okay, so the first thing that I am going to note is the pulse rate. Okay, so I am going to palpate the pulse and simultaneously measure the time. So ideally I should count for a full 60 seconds, but practically it's okay if we count for 15 seconds and then multiply that value by 4 to get the pulse rate over 60 seconds. And this is in case the patient has a regular pulse. If the patient does not have a regular pulse, if the pulse is irregular, then I must count for a full 60 seconds. Okay, so the normal pulse rate is 60 to 100 beats per minute. If the pulse is less than 60, then the patient has bradycardia. If the pulse is more than 100, then the patient has tachycardia. Okay, so next I will assess the rhythm of the pulse. Okay, and to assess the rhythm, I will assess and analyze the intervals between the pulse. Okay, so if all of the intervals between the pulses are equal, then the rhythm is regular. But if they are not equal, then the rhythm is irregular. So if I find that the pulse is irregular, then I will have to further subclassify it into regularly irregular pulse and irregularly irregular pulse. Okay, so if the pulse is irregular but it follows a set pattern, if the pulse is predictable, for example, if we feel 3 pulses followed by a pause, 3 pulses followed by a pause, and then repeated over and over again, then it is predictable and it follows a set pattern, then it is regularly irregular. So it is seen in second degree art block. Okay. But if the intervals between the pulses are completely random and the pulse cannot be predicted and it does not follow a set pattern, then it is irregularly irregular. Okay, so irregularly irregular pulse is seen in patients with atrial fibrillation. Okay, so after the rhythm, next I will assess the volume. Okay, so for volume I am going to analyze the intensity of the pulse. Okay, how hard does the pulse hit my hand, or how hard does the pulse hit my fingers. Okay, so that is how I am going to assess for the volume. and this is a subjective assessment, and it might be difficult for you to assess and comment on the volume when you are new to clinical examination, but with experience and practice you will be able to do it. Okay, so this pulse volume represents the pulse pressure or the stroke volume. Okay, so that is what it represents, and pulse volume is increased in some physiological conditions like exercise or pregnancy, and it can be increased in some pathological conditions like aortic regurgitation or anemia, thyrotoxicosis. Those are some of the conditions in which pulse volume is high. Okay, so low pulse volume is seen in patients with dehydration or in patients with shock. Okay, so those are some of the important conditions. Then we will assess the character of the pulse. Okay, so to assess the character, we will need to analyze the waveform of the pulse. So there are certain pathologies which have certain characteristic waveforms, but these are very difficult to identify solely on the basis of palpation of the pulse. Okay, so but there are some characteristic waveforms. One important character of pulse is the water hammer pulse or the collapsing pulse. Okay, so and this is seen in patients with aortic regurgitation classically, but it is also seen in patients with hyperdynamic circulation, for example, anemia, thyrotoxicosis. So it can also be seen in those patients. And this water hammer pulse is characterized by a sharp rise and ill sustainability and sharp fall. Okay, so the peak of the pulse is ill sustained and it falls sharply. This ill sustainability and sharp fall gives it the characteristic collapsing nature of the pulse. Okay, and there is a technique to accentuate the collapsing nature of the pulse and confirm our finding of water hammer pulse. So this specific maneuver, what we do in this specific maneuver is we basically raise the hand above the head of the patient and then we palpate the pulse. Okay, but the specific technique is that first we have to ensure that the patient does not have any pathology of the shoulder or the arm. We have to ensure that he does not have any shoulder or arm pain. Then we will palpate the radial pulse with the base of our fingers. Okay, so we are going to use the base. Previously we used the pulse, now we are going to use the base. Okay. So and then we will hold his wrist, simultaneously palpating the radial pulse with the base of our fingers. Okay. Then we will support his elbow and arm with our free hand, and then we will gently but swiftly raise his hand above his head, and then we will palpate the radial pulse. Okay, so this is how we are going to do it. Okay, so if the patient had a collapsing pulse, then the nature of the collapse would accentuate. It will be more prominent. Okay, so that was one of the characters of pulse. And the volume and character of pulse is best assessed in the carotid artery. Okay, ideally the volume and character should be assessed in the carotid artery, but it can also be assessed in the radial artery. Okay, so next we are going to palpate both the right and left radial artery simultaneously to look for radio-radial delay. Okay. So I am going to palpate his right radial pulse with my left hand and his left radial pulse with my right hand. Okay. So I will palpate both of them simultaneously and I will feel for any delay. Okay. In a normal patient, there should be no delay. Okay. So if there is any delay between those two radial pulses, then it signifies the presence of some pathology. Some causes of radio-radial delay include atherosclerotic occlusion, occlusion due to thromboembolism, coarctation of aorta, subclavian coarctation of aorta, so specific subset of coarctation of aorta, and aortic dissection. Those are some of the causes, okay, of radio-radial delay. Next, we will palpate for the condition of the arterial wall. Okay, so to assess the condition of the arterial wall, what we will do is we will roll the artery with our fingers over the bone. Okay, so we will assess the condition of the arterial wall with a rolling motion to palpate for the arterial wall. Normally the arterial wall is not palpable or it is soft, but if it is hard like a cord, then it signifies the presence of atherosclerosis or calcification or some pathology. Okay, so this much for the radial artery. Okay, so next we will move on to the brachial artery. Okay, so to examine the brachial artery, we need to expose the antecubital fossa. So we will palpate for the brachial artery in the antecubital fossa, just medial to the tendon of biceps brachii. Okay, so first we need to identify the tendon of biceps brachii, and if it is difficult for us to identify the tendon, then we will ask the patient to flex his elbow. Okay, when he flexes the elbow, the tendon becomes prominent, and then we can palpate the tendon. Then we will palpate for the brachial pulse just medial to the tendon in the antecubital fossa. Okay, we can use the thumb and support the elbow with our fingers. This is acceptable, and we can also use our 3 fingers to palpate the brachial artery. Okay, it's okay to use the left hand as well. Okay, so then we should also palpate the brachial pulse on the opposite side. Okay, next we will move on to the carotid artery. So for the carotid artery, we will palpate just medial to the sternocleidomastoid muscle, just medial to this sternocleidomastoid muscle at the level of the cricoid cartilage. Okay, so this is where we are going to palpate for the carotid artery. Okay. Just medial to the sternocleidomastoid muscle at the level of the cricoid cartilage. Okay, so this is where we are going to palpate for the carotid artery. Okay, so the thing to keep in mind is we should avoid appearing as if we are going to strangulate the patient. Okay, so I am using my left hand, so instead if I just use my right hand, then I was going to appear as if I am going to strangulate the patient. So if I am going to palpate his right carotid, it's best to use my left hand. I can use either 3 fingers or I can use my thumb. Both are fine. Okay, and if I am going to palpate his left carotid, then I am going to use my right hand. Okay, 3 fingers or the thumb. And the next thing that we need to keep in mind is to not apply too much pressure and do not palpate both the carotids at the same time. Okay, because if we apply too much pressure or palpate bilaterally, then it can lead to vasovagal syncope. Okay, then in the carotid artery we should also assess for character and volume of pulse. So next we will move to the lower limb, first for the femoral pulse. Okay, so for the femoral pulse, the patient should be in the supine position and the inguinal region should be exposed, but that is not possible right now, so I am just going to show the surface landmarks by asking to stand up. Okay, so first we need to identify the mid-inguinal point. Okay, so the mid-inguinal point is at the midpoint between the anterior superior iliac spine and the pubic symphysis. Okay, so we will identify the mid-inguinal point and then we will palpate just inferior to the mid-inguinal point along the femoral artery. Okay, so that is where we are going to palpate for the femoral pulse. Okay, then we will also assess for radiofemoral delay. I am palpating the femoral artery with my right hand and radial artery with my left hand. Okay, so then I am going to assess for any delay. Okay, again the causes are the same: thromboembolism, atherosclerosis, coarctation of aorta, aortic dissection. They will cause radiofemoral delay. Okay, and then next I should also palpate the femoral artery on the opposite side. Okay, so you can sit down. Next, for the popliteal pulse, again the patient should be in the supine position and the popliteal region should be exposed, and there is a special position for popliteal pulse. Let us move this chair over there and then I will try to demonstrate it. Sit down. So in the supine position, the knees should be flexed by 30 degrees from the horizon. Okay, so that is not possible right now, because I will just try to demonstrate it. Okay, so if suppose you are in a supine position and his knees were flexed by 30 degrees from the horizontal, then and his knees and popliteal fossa were exposed, then my thumbs will be on the tibial tuberosity, and then I would palpate with both of my hands using the 3 fingers. Okay, my 3 fingers will be placed in the popliteal fossa in the midline, 2 to 3 centimeters below the skin fold in the popliteal fossa. Okay, so that is where I will palpate for the popliteal pulse. Okay, and then I would again repeat it on the opposite side. Okay, again, so this will be done in the supine position with knees flexed by 30 degrees and popliteal fossa exposed. Okay, so next for the dorsalis pedis pulse, you need to open your shoes and socks. Okay, so for the dorsalis pedis pulse, the location of the dorsalis pedis pulse is just lateral to the tendon of extensor hallucis longus. Okay, so the extensor hallucis longus supplies the great toe and extends the great toe. So I will ask him to extend his great toe. So this tendon is prominent now. This is the tendon of extensor hallucis longus, and I will palpate for the dorsalis pedis pulse just lateral to this tendon over the proximal part of the foot. Okay, so this is where I am going to palpate for the dorsalis pedis pulse. Okay, and then I should repeat this again on the right foot. Next for the posterior tibial pulse. So for the posterior tibial pulse, I will palpate 2 centimeters below and 2 centimeters behind the medial malleolus. So this is the side where I will palpate for the posterior tibial pulse. Okay, and again I should repeat this on the opposite side. So to measure the blood pressure, first there are a set of precautions that you need to take before you measure the blood pressure. First, the patient should not have exercised for 30 minutes prior to measurement of blood pressure. The patient should not have consumed any caffeine for 30 minutes prior to measuring blood pressure, and the patient should not have smoked for 30 minutes prior to measuring blood pressure. Have you? Okay, then we are fine. And after the patient comes to you, you should ask the patient to rest for 5 minutes, at least for 5 minutes before you measure the blood pressure. Okay, then the patient should be seated in the sitting position or in the supine position. Both of them are fine, and the back should be supported, so you need to lean back. Okay, and the legs should be uncrossed. If the legs are crossed or the back is not supported, then that can lead to falsely elevated blood pressure measurements. Okay, so then we will prepare the blood pressure cuff. So usually the standard size is okay for most patients, but if you want to confirm the size of the blood pressure, then you need to measure the mid upper arm circumference. Okay, so how we measure the mid upper arm circumference is, we first identify the midpoint of the arm. So the midpoint of the arm between the acromion process and the olecranon process. Okay, so we need to identify the midpoint between these two processes. So we will measure the length from acromion to olecranon, and then we will measure the mid upper arm circumference at the level of the midpoint. Okay, so this is how we are going to measure mid upper arm circumference. And then how we confirm the size next is the length of the bladder of the blood pressure cuff. Okay, so there is a bladder in this. The length of this bladder from here till here, not the entire length, just the length of the bladder, should be 80% of the mid upper arm circumference, and the breadth of the bladder should be 40% of the mid upper arm circumference. Okay, so now once we have confirmed the size, next we will prepare the arm. Okay, so how we prepare the arm is, the arm should be exposed. Okay, so this should be exposed, and thick clothes are not acceptable, and tight clothes are not acceptable, and rolling up of clothes is not acceptable as well, but a thin layer of clothing might be acceptable. Okay, a thin layer of clothing is fine. So next, this arm should be supported. Okay, it should not hang freely as it is right now. So come a little bit closer to the table. Okay, and then okay, and then this sit straight. Okay. And then this arm is being supported by the table, and his arm should be at the level of his heart. Okay, to ensure that we don't take false measurements. Okay, so now that we will insert this much, next we will use the blood pressure cuff. Okay, so the midpoint of the bladder. Okay, so the midpoint of this bladder should be over the artery. Okay, so some BP cuffs have markings for the artery, some do not, but the midpoint of this BP cuff should be over the brachial artery, and the blood pressure cuff should be placed in such a way that there is at least 3 centimeters distance between the antecubital fossa and the blood pressure cuff for you to place the stethoscope over there. Okay, so then we will fit the blood pressure cuff snugly, and then we will place this gauge at the level of the heart, okay, or at the level of the blood pressure cuff, and this gauge or this scale should be facing the examiner. Okay, we should not place it over here or over here on the back. It should be facing the examiner. Okay, so next we will measure the blood pressure using 2 methods, palpatory method and auscultatory method. Okay, so using palpatory method, we will estimate the systolic blood pressure, and then using the auscultatory method, we will confirm the systolic and diastolic blood pressure. Okay, why we are using 2 methods is the auscultatory method sometimes may give falsely low BP readings if phenomenon known as auscultatory gap is present in the patient. Okay, if the patient has an auscultatory gap, it affects the auscultatory method and leads to falsely low blood pressure readings. So, but this auscultatory gap will not affect the palpatory method. Okay, so the palpatory method will protect us from recording falsely low blood pressure readings. So for the palpatory method, what I will do is I will slowly inflate the cuff, and then I will note the pressure reading at which I will no longer be able to palpate a pulse. Okay, so I should be simultaneously palpating the pulse. Okay. So I can palpate either the radial or the brachial pulse. Anyone is fine. And for the purpose of this demonstration, I will be palpating the radial pulse. Okay, and then I will slowly inflate the blood pressure cuff till I will slowly inflate the blood pressure cuff, and I will note the point at which I will no longer feel a pulse. Okay, so now I'm going to do that. Okay, so I did not feel a pulse above 120 millimeters of mercury. Okay, so my estimation of the systolic blood pressure is 120 millimeters of mercury. Okay, so next for the auscultatory method, I will rapidly inflate the blood pressure cuff up to the pressure reading 30 millimeters of mercury beyond what I just estimated. Okay, so I will add 30 to 120 to get 150. So I will rapidly inflate the blood pressure cuff till 150 millimeters of mercury, and then I will slowly deflate the cuff at the rate of 2 millimeters of mercury per second. While I am slowly deflating the cuff, I will listen for throat cough sound. There are 5 phases of throat cough sound. The first phase is when I will hear a thud. Second, I will hear loud blowing noises. Then again in the third phase, I will hear soft thuds. And then I will hear muffling in the fourth phase and no sound in the fifth phase. Okay, so I will specifically note the first and fifth phase. When the thuds appear, the first phase, which represents the systolic blood pressure, and when the sounds disappear, the fifth phase, which represents the diastolic blood pressure. Okay, so I will note those 2 points. Okay. So now I am going to demonstrate it. So again I am palpating the tendon of biceps and then placing the stethoscope just medial to it. Then I'm inflating till 150. Okay, so after I have noted the fifth phase of total cough sounds, after I have noted the diastolic blood pressure, then I can deflate the cough rapidly. Okay, so I heard the third sounds at 120 millimeters of mercury, and I noted the disappearance of sounds at 80 millimeters of mercury. So his blood pressure is 120 systolic, 80 diastolic. Okay, so then we will record the blood pressure. Then what we should do is, we should measure the blood pressure on the left side as well. And if they are different, then we will report the higher one. We will report the higher blood pressure out of the two arms. Okay. So, while reporting the blood pressure, we should always report the blood pressure in even numbers, no odd numbers, because this gauge itself is calibrated in increments of 2 millimeters of mercury. Okay. So we will always report in even numbers. Okay, so if the blood pressure is more than 120 systolic and 80 diastolic, then the blood pressure is elevated. If it is less than 90 systolic, 60 diastolic, then it is decreased. Okay, so sometimes we may need to assess for postural hypotension. Okay, so postural hypotension is when the patient has markedly decreased blood pressure when he stands up. Okay. So if the history is suggestive of postural hypertension, then we will need to assess for it. How we will assess for it is, we will first measure the blood pressure while the patient is supine. The patient should be in the supine position for at least 5 minutes, and then we will measure the blood pressure in the supine position. Then we will ask the patient to stand up, and after 2 minutes of standing up, we will measure the blood pressure again. If the systolic blood pressure decreases by more than 20 millimeters of mercury, then the patient has postural hypertension. Okay, so next we will talk about the respiratory rate. Okay, so to assess the respiratory rate, I will need to observe the respiratory movements of the patient. Okay, but one thing to keep in mind is, we should not tell the patient that we are measuring the respiratory rate, otherwise they may get conscious and alter the respiratory rate. So the patient should not know about it. And if it is difficult for us to appreciate the respiratory movement, then we can place our hand over the abdomen, and this will make it easier for us to appreciate the respiratory movement. Or we can also pretend as if we are measuring the pulse, and then actually measure the respiratory rate while looking at our watch. Okay. And again here as well, ideally we should measure the respiratory rate for 60 seconds. But if the respiration is regular, then we can measure for 15 seconds and multiply by 4. But if the respirations are irregular, then we must measure for a full 60 seconds. Okay. So after the respiratory rate, we will note the rhythm of the respiration. And normally the respiration is regular, and there are some characteristic irregular respiratory pattern. One of them is Saint-Stokes breathing. Saint-Stokes breathing, and this Saint-Stokes breathing is typically present in patients with heart failure. And what happens is, the patient will have cyclical alternating periods of deep and shallow respiration. Okay. So that is present in patients with heart failure. Then next we will assess for the type of breathing, whether the breathing is abdominal thoracic or thoraco-abdominal. In abdominal thoracic, the abdominal movements are more prominent than the chest movement. This is classically seen in males. And in thoraco-abdominal, the chest movement is more prominent than the abdominal movement. This is classically seen in women and children. Okay. So next, after the respiratory rate, we will measure the temperature with a thermometer. And this is an electronic thermometer. And we will place the thermometer in the axilla. The bulb of the thermometer or the tip of the thermometer should be in contact with the skin. And it might need up to 5 minutes for the temperature between the bulb and the skin to equilibrate and after equilibration we will measure the reading of the thermometer, and this one is an electronic one, so this will make sound after the equilibration, and then we will take the reading. Okay, so we talked about pulse, blood pressure, respiratory rate and temperature. And if we suspect that the patient has a cardiorespiratory pathology, then we will also need to measure the oxygen saturation in the peripheral blood, or SpO2, and we will also need to measure the jugular venous pressure. This is if we suspect that the patient has a cardiorespiratory pathology. Okay, so this is all that we will talk about today in vital signs. Okay, thank you.